Bismillahirrahmanirrahim. Today we will have case quiz number 26. Case data 38 years old female. 38 years old female. Non SLE systemic lupus erythematosus in remission. Controlled with steroid hydroxychloroquine and azathioprine. The patient presented to emergency department with acute pleuritic chest pain and breathlessness. The patient had no cough, infective symptoms, or risk factors for DVT. The patient had history of single second trimester miscarriage. Examination revealed the patient was uncomfortable on bed with short of breathlessness at rest with respiratory rate 16 cycles per minute. The pulse was somewhat tachycardic, 96 per minute, but sinus rhythm. Blood pressure 115 over 80 over 68 within normal. Oxygen saturation limited or deteriorated to 90% only. The patient had no fever. Investigation revealed hemoglobin within normal 14.9, YBCs within normal 5.6, platelet there is thrombocytopenia 98 only, C3 and C4 were normal, ANA was positive by immunofluorescence homogeneous pattern with a titer of 1 over 80. X-ray chest. This is the X-ray of this case. Look at the X-ray and then answer the question. So, what is the diagnosis? The answer is pulmonary embolism, of course, pulmonary embolism. Pulmonary embolism. The likely diagnosis for this patient's current presentation is pulmonary embolism. The history of sudden onset pleuritic chest pain and shortness of breath is characteristic of pulmonary embolism, and the normal respiratory examination and chest X-ray is highly supportive as is the hypoxia. So hypoxia here is very important. Although an ECG may demonstrate right heart strain in patients with large emboli, the most common finding is simply sinus tachycardia or new onset atrial fibrillation in the elderly. The diagnosis or the diagnostic test for pulmonary embolism is a CT pulmonary angiogram (CTPA), and the patient should be anticoagulated in anticipation of positive result. The history of lupus is highly relevant, and in combination with a previous pregnancy loss and mild thrombocytopenia raise the possibility of antiphospholipid syndrome. Antiphospholipid syndrome is a hypercoagulable state characterized by recurrent arteriovenous thrombosis and or pregnancy loss or morbidity in the presence of either a lupus anticoagulant or anticardiolipin antibodies, both phospholipid-related proteins and some other proteins than these two. The term lupus anticoagulant is admittedly confusing in a pro-thrombotic state, but the in vitro test relies on the prolonged coagulation that is corrected not by addition of a clotting factor, but rather by addition of phospholipid in excess. Although the antiphospholipid syndrome was originally described in lupus, its occurrence doesn't correlate with the disease activity, and it may indeed occur in patients with no clinical or serological evidence of lupus, what is called primary antiphospholipid syndrome. The most common arteriovenous thrombotic events in antiphospholipid syndrome are deep venous thrombosis and pulmonary embolism, as in this case. But any part of the circulation may be involved with arterial events such as myocardial infarction and stroke carrying a high mortality rate. Poor placental circulation is thought to be responsible for a high pregnancy morbidity with recurrent first and second trimester loss and higher rate of pre-eclampsia being typical clinical features. And finally, thank you very much for your attendance, and we will meet you in the next future with case quiz number 27. Wassalamu alaikum wa rahmatullahi wa barakatuh.